Thank you very much, all of you, for helping to understand the orthopedic issues that emerge in acute flaccid myelitis. For me, as a clinician and neurologist, actually, it's a good refreshment about all of these topics related with spine, bones, joints. But it's amazing also to hear from Bradley, and I am amazed to see Luca jumping around and playing with that football. Christina, I will pass the microphone to you.
Well, thank you. So I'll start with Riley because she was the first one to present, and of course you have a very compelling story because you're the clinician, researcher, and parent. So because of the study that you did, I was curious, did you find a lot of similarities in the answers from the other parents? Did the answer match your experience?
So yeah, to your question about whether there were similarities, Christina, so absolutely. I think one of the things I tried to draw out was the fact that, you know, I had this unbelievable exposure to Leslie Benson within 5 minutes of my suspecting that Luca was sick, right? Leslie and I trained together, and I just sent her a video and had that exposure. And she wrote back, she said, "Oh my gosh, I'm worried it's AFM." And yet, despite that, I still, despite, being Harvard Medical School faculty myself and taking my son in to a great place for pediatrics, they still didn't do a neuro exam, right? There was still a lot of problems initially at onset with the sort of pre-hospital diagnosis, and then the rehabilitation. I think that the field has really learned since 2014, but there was very, very little known, and so I think that really parallels what the other parents experienced as well. Lack of initial neurological evaluation, lack of any really clarity on what kids should be given while inpatient, lack of understanding of long-term outcomes and what interventions helped. And really everyone here today has played such a big role in moving the field forward. But I think a lot of parents had the same, unmet needs, that same experience. And thankfully, things are becoming there's more and more of a sense that there's a community around parents now, and that these clinicians have really made it a mandate to kind of resolve some of the gaps.
Well, thank you. Actually, this community, you are helping keeping us all together and motivated because the way that the community got together, the parents, Facebook, AFM group, it's a major move forward and it motivates all of us to do better. Andrea, I was asking about the tendon transfers because obviously so I'd like to ask you about, is there a reversibility to them? And when do you say, okay, we can't do nerve transplants anymore. We have to think a tendon transfer.
So I'll be really interested to hear what the other speakers say about that too. And your next session. We typically would say we want to get a nerve transfer done within 6 to 12 months after the onset of injury. And we have a tricky time window because during the first 6 months, we're seeing so much recovery. And so we don't want to jump the gun too soon and do a surgery that's not necessary. Definitely after a year, the results go down. And so that's when the tendon transfers would come into play. And there is no time limit on the tendon transfers. So I think what happened a lot after the 2018 outbreak is that we saw patients from 2014 or 2016 who are now getting connected and saying, hey, can you do something about my arm? And so people who were, 2 to 4 years out, that we could then help with the tendon transfer when certainly a nerve transfer would not work at that time frame.
How about because your talk actually made me think of the fact that we have very few solutions for shoulder and hip. And Dr. Watkins, I know I'm going to go back to you to the hip question. And the shoulder and hip is really, truly affected in the children with AFM. Would you consider early stabilization with a tendon transfer so you can allow for better biomechanics of the shoulder? Because we have no good bracing, No, nothing. So what do you think on that?
I think that's a great point, and it's not something we have done, but it's clear that that instability affects the ability of the other muscles that have a nerve supply to do their job. And so it's something to consider. And there's other ways besides the trapezius transfer that you could stabilize the shoulder, but it's definitely something to think about, whether we should be doing those sorts of things earlier. We haven't, I think, standard, in the past because we just haven't seen patients soon enough.
Yeah, but I guess that's the reason why we have this meeting of the minds to think forward.
Yeah.
So, Colin, I know we have no experience with children with AFM in the hip, and again, hip is a major issue because these children are small and don't have the acetabulum well developed, and it just slides out. And you use the spina bifida. Do you think that there is a difference in the fact that one is congenital and the other one is acquired when it comes to outcomes?
Yeah, absolutely. I think there is a difference when you've spina bifida is absolutely different than AFM. But I think you tend to see a similar phenotype depending on how affected a child is in terms of their neurologic deficit. I think one of the things about the hip tendon transfers is that a lot of time the tendon that you take is actually doing something, and then you lose that, and you've taken the best example is probably a transfer of the hip flexor tendon, which is actually very helpful if you're ambulatory to go upstairs, and if you're non-ambulatory, it helps get your knee to your chest to like change your shoes and things like that. And so I think, and when you take it and move it elsewhere, you lose a grade of strength moving it, and so you're taking something that's working and has a function and hoping that when you move it, it does what you want it to do, knowing that it will be weaker. And I think that's the trouble, is that there's no free lunch, I suppose, in it. You lose a little bit when you move the tendon.
So I have a question.
Yeah.
So with Riley, we are the clinicians here in the group, but I frequently see patients just during the acute phase, and most of them also during the subacute phase. So, and the approach that the medical team should take and the healthcare team is just to have a multidisciplinary approach. My question is, talking with orthopedic surgeon just when the patient is in the acute phase is probably too premature. So, in your experience, Colin and Andy, when is the best time to go and ask you for coming in and participate in the discussion? I like to plan ahead of time and have plan A, B, and C. But I think that many of your topics actually are very well related and intertwined, even at the beginning, because you are able to forecast in many ways what is going to be the outcome, particularly for patients that come to our intensive care units and are paralyzed for a long time, are intubated for 2 or 3 weeks. So we know that that patient eventually is going to experience a lot of problems. So in your experience, what should be the first interaction, at what time, and what do you recommend for the healthcare team in terms of communication, interaction, and questions between you, the parents, family, and the medical healthcare team?
I can start, Andy. I would I like to be involved pretty early. I don't, I've definitely seen children in the ICU just to help with bracing and kind of what's safe for range of motion. And I don't think there's necessarily too early of a time. And I also like to kind of know the trajectory, and it helps to understand the trajectory when you're there at the beginning. So I think it's helpful from the start.
I think it depends too on what your team is. So we're fortunate that we have Dr. Benson, and we meet with her regularly. So she knows what we would say and can start that conversation earlier without necessarily us overwhelming the family with information while their child is still in the ICU. So I think it depends on the family. It depends on your setup with your team. We also have PM&R on our team that can be a helpful it can be helpful in the short term, like in the ICU setting. And then I think early, you know, if not in the ICU, then certainly once a child is done with acute rehab, our goal is to provide a positive message, you know, that when we get through this acute phase, that we have things that we can offer and we have things that will help. And that's, you know, so whenever the family is ready to hear those things, I think we want to be involved and share some options.
I think that one important conclusion, probably as a good message for the audience here and also for people that are going to be looking at these lectures later, is it's extremely important, regardless the institution where you are, that patient be taken care by a multidisciplinary team that should include an orthopedic specialist as well. In the same way that we are bringing our rehabilitation colleagues and other specialists, it's extremely important to have people, identify people with expertise in orthopedics. Christina, back to you.
Yeah, so back to Riley. I'm going to ask you about your finding in the study about bowel and bladder issues that seem to be quite prevalent. We typically, as clinicians in the acute and subacute phase, we don't recognize as bowel and bladder being major issues in children with AFM. We actually say that there are not a lot of neurologic deficit there, but you found differently. Could you comment a little bit?
Yeah, sure. So I think, you know, the first thing is this is parent reported. And so it's possible that the bowel and bladder issues included sort of bladder issues from kids who are unable to get up and go to the bathroom, for instance, or so perhaps not always neurogenic bladder, or kids who are having sort of, you know, side effects of the antibiotics or other sort of experimental therapies they were given. Perhaps if they had, you know, pulmonary infections or something and they were given antibiotics in addition to sort of their typical AFM treatment, perhaps there is some there. But I think what a lot of the parents report, and this is, of course, per parent report, is there is also some white matter involvement, perhaps as a bystander, right? Of, you know, we understand that the AFM, the virus, isn't targeting the white matter necessarily, but just the sort of the bystander with the inflammation or such, there is some white matter involvement. And similarly, a lot of the kids have pain and some sensory issues at some points as well. And so I think that part we don't think of so much as purely sort of a motor AFM picture, but it was definitely prevalent in the surveys. Mm-hmm.
Thank you. That's really important. I think that because other speakers brought up the idea of spasticity as a component, and it's not typically recognized again, but when we look at the white matter as a bystander involved, then that happens. I'm going to go to a question to about the balance in between bracing and allowing for the muscle to functionally strengthen. And I'm going to look at Colin and Andy on giving those answers, and then probably Riley, she can talk about what Luca went through. So
I'll leave that one to Colin.
Yeah, I think that's a great question. I think the role of bracing, you know, it should be it's a functional assist. So hopefully when the child has the brace on, they feel like they're better with it than without it. And so there's definitely a balance of, you know, for longer distances, maybe you have the brace, but for, you know, around the house, you try some time without of the brace. So you get kind of the best of both in the sense that, you know, barefoot or just a shoe inside the house so that you're developing some of those weaker muscles. But, you know, functionally, when you're out of the house and you're a little bit weaker on one side or both sides, it's nice to have that brace to support you so you're less fatigued and you can do more. But I typically say, you know, I want some time out of the brace as well, unless it's a true kind of flail extremity that have no motor function, and the brace is typically helpful all the time.
Riley.
Yeah, you know, as a parent here, I have to say, I think it's so dynamic, right? Because you have the safety concerns, you have the sort of joint stabilization concerns, and then you have sort of the functional recovery concerns. And I think at different times, you know, those requirements change throughout the day when the kid's in school, you know. So Luca is in school, and once I was able to trust the teachers, you know, we were able to say, well, you don't wear the neck brace in class, but as soon as you go out to the playground, you wear the neck brace, because if he was braced all the time, he would never regain that neck strength. And then at home, we can take the neck brace off and actually do exercises to try to increase strength. And so it's very, very dynamic. It really depends on who's around the child and whether the parent is, has other kids, is working, and so you have to I think you have to have dedicated time to each of those things. Certainly safety comes first, and then you try to, allow them as much freedom to recover things as much as they can. I think if you were to examine Luca, for instance, if you were to do a motor exam that was just sort of the standard neurological motor exam, you would have no idea how he can raise his arm to catch a football, because you would almost give him a 0 for power in all of those shoulder muscle groups. And yet you could see him clearly grabbing a football in the air, and he clearly couldn't do that. And so much of sort of the other muscles and the rest of it comes into play, and I think is important for the strength of the bones long term. So if you were to just brace that up to preserve the shoulder, you'd probably lose a lot of that functional recovery. So it's just very dynamic, and having the ongoing rehabilitation specialists, having access to them to help prioritize those things as the child grows, I think is just so key.
That's actually yeah, go ahead.
One question in terms of the bone growth. Last session, actually, Christina and I gave a very interesting review of bone biology, and particularly the calcification and the need to be alert on issues related with the ongoing growth of the bone and the biology of the bone. What would be your recommendation in terms of particularly for the parents, is to pay attention, for example, to a medical approach to facilitate a better recovery of the bone health and the joint health after AFM? I don't know if, Christina, you'd like to mention what you describe in your observations here.
Yeah, we found that out of the 33 children that we looked at their bone density, that 78%, almost 80% of them had low bone mass by DEXA. And in those, and we looked at 73 kids, and we had 19 fractures, with some of the kiddos having up to 6 fractures per child. So this plays very much into what the orthopedic surgeons can do further, because how are you going to do to have a good fusion in any way, put a screw into a bone that is basically decalcified? I don't know if you have any suggestions, like or knowledge on how to spare that bone and how early.
We've been following your lead on this. I think we've been trying to figure out, should we be doing some screening earlier on? And I think certainly I agree with what Riley said, that we want to maintain as much activity as we can. We know that weight bearing is good for bone density, so using the limbs that are affected is good for bone density. Beyond that, I think when it gets to like medical treatment that have risks, we still need to understand, what is the risk of osteoporosis? Is it just in the affected limb? Is it in the whole child? Who is affected by that most? Which I don't think we still understand yet, because we have some other kids that don't have this problem at all.
And I'd say from like a functional standpoint, I always encourage weight bearing, no matter what the joint looks like. I think the benefit of weight bearing outweighs, an x-ray that's imperfect. So I never say like, oh, well, your hip is, we have to protect your hip, don't weight bear or anything like that. I think the benefit of that always outweighs whatever issue you might have by weight bearing on an imperfect joint, which I don't really think there is one if the patient is not symptomatic from it.
Yeah, actually, I think I heard orthopedic surgeons talking about recurvatum and saying, forget about recurvatum, just weight bear, we were all taught, okay, protect the knee because it goes backwards. It's like, forget, we can solve that, just weight bear. And actually, in the series that I presented, the children that were weight bearing had better distal femur bone mass. I think
Thank you very much for all of your effort and participation. It has been very nice to hear from all of you, and very nice to hear from Riley and the experience that you have for orthopedic problems is very helpful for all our audience. We are going to move now to the stage again to listen our colleague from surgery and on nerve transfers, and we will start with Dr. Alan Belsberg. And again, thank you all of you for your great support for the acute flaccid myelitis community. Thank you.
Thank you.
Thank you.
Thank you.
Take care, guys.